Good afternoon, everyone. I think we can start now. I I said we'll start 5 minutes after 3, so I think it's just few minutes. Yeah, I think it's time now. We can start now. So this afternoon I'll be introducing our guest speaker who will be talking on a topic beyond the clinic, or journey in bring the clinical orthodontics and basic research. His name is Dr. Janvier Habumugisha. Dr. Habumugisha is a researcher and a clinician in orthodontics, skills in molecular biology. He earned his PhD from Okayama University, Japan, his Masters of Dental Surgery in Orthodontics from the Z in Zhuangtong University, China. During his training, he conducted clinical and basic research, including studies on osteoarthritis, upper airway volume prediction using 3D MRI and craniofacial morphology assessment. His research focuses on clinical predictions, models in orthodontics, airway assessment, obstructive sleep apnea, mouth breathing, the molecular mechanism of musculoskeletal diseases, and translation approaches, bringing basic science and clinical practice. And Dr. Habumugisha is well published and served as a peer reviewer for more than 15 index journals. Join me to welcome Dr. Habumugisha. Thank you for coming and honoring our invitation this afternoon. Thank you, sir.
Thank you so much, Doctor, for your nice talk and great introduction to me. So, my name is Janvier Habumugisha from Rwanda. I'm sorry, my name is very difficult to pronounce. So, today I will talk on my journey from clinical orthodontic to basic research. So I will just brief introduce myself. As I say, my name is Janvier Habumugisha, Rwandan by nationality, and I'm currently here in Kigali, Rwanda. And for contact information, you can contact me via this email address and phone number. And I will talk about my education. I graduated from University of Rwanda in 2016 for my bachelor's degree in dental school, and I continued my school for specialty in orthodontic from Xi'an Jiaotongou University. This is one university in China. Then in 2025, I got my PhD from Okayama University, Japan. From this picture, you can see here I was very young during my undergraduate course with at University of Rwanda. This is actually former Chancellor of University of Rwanda. Here I got Best Student Award at this time. It was 2016. This picture, I was in China for my master's degree in orthodontic as my specialty, treating patient. This is me, this is patient, this is my nurse, assistant nurse. So this is during our final defense at Xi'an Jiaotongou University. This is me and my professor, Professor Fei, and my colleague, Dr. Ma. So this is a recent picture in 2025 when I got my PhD from Okayama University with my supervisor, Professor Kamioka. This is, you can see here. So after, I can talk about my research, but I need also to say I'm a reviewer, review member of most orthodontic journals, including American Journal of Orthodontic and Dentofacial Orthopedic. I think this is famous magazine, AGODO, and also I'm a reviewer for Progress in Orthodontic. Also, I think now it's #1 orthodontic journal in terms of impact factor. I'm also a reviewer in International Orthodontic and BMC Oral Health, Journal of Pediatric, Clinical Pediatric Dentistry. Journal of Clinical Medicine, International Journal of Molecular Science, Dentistry Journal, Oral Health, several, more than 20 journals I'm serving as a reviewer. So my research mainly focus on airway, clinical research. So today my part will focus on clinical research and basic research. But I want to talk first on clinical research, and then I will finish on translating to basic research, how orthodontists or dentists in general can translate from clinical research to basic research. Is it possible? So we'll see that. So my research focused mainly on airway, mouth breathing, OSA, obstructive sleep apnea. So why I just want to talk about this orthodontist or dentist in general. It's not about caring about teeth. We need also to care about function. So one of the major components of this multidisciplinary, I can say approach or treatment approach, it may involve airway. Because before, orthodontists were focusing on just aesthetic, but that's not enough actually, because some orthodontic treatment may affect upper airway, and that may lead to very serious issue. Even patient may die. There are some cases where people perform like mandibular setback surgery, then they narrow airway of patient, then the patient end up with OSA, obstructive sleep apnea, and in some cases people die from that kind of incidents. So we need to avoid this like orthodontist or dentist in general who can perform orthodontic treatment. So we need to know which stage we should do this treatment. And this may affect hyoid bone, airway, and other function. So we need to care about that one. So that's why understanding airway health helps orthodontists to make functional, stable, and health-oriented treatment outcome or treatment decision. So because some orthodontic and orthodontic appliances or orthodontic surgery, as I mentioned, may affect airway. So this is very crucial for orthodontists. You can see this picture. I'm not sure if you can see it clearly, but it's showing two different aspects. This is normal breathing partner where your tongue is, let's say in this second picture, you can see tongue side obstruct airway. It's like there is narrow airway space in OSA patient. Those patients with obstructive sleep apnea usually have very narrow retropalatal and retroglossal airway, and they may have a very big trouble during their sleeping. So they may have issue with respiration, and this may affect their overall health because if someone is not sleeping well at night, next day, maybe it's very difficult to go for work. For kids, it will be difficult for them to attend school. Or say actually affect children for their performance at school. So it's very crucial for orthodontists to know those kind of events which may happen if airway and other factors. Of course, OSA is associated with other factor, which are obesity or other congenital issues, but today I will talk mainly on upper airway, how it may affect patient and orthodontic patient and their overall health outcome. So my research in 2022, end of 2022, I did research. Excuse me, I did research on airway, about airway, pharyngeal airway in the maxillary arch. So my main focus was to compare mouth breathing and nasal breathing children. Those are Chinese children aged 10 to 12. So we found that mouth breathing subject had narrow maxilla. Their maxilla were constricted and compared to nasal breathing. intermolar width, and canine width, and maxillary arch were very constricted in mouth breathing. And those data were significant between those two groups. And also surprisingly, or if even maybe someone can assume that outcome, but mouth breathing subject has narrow airway, especially at oropharyngeal region. This is very critical because association between adenoid hypertrophy and upper airway was topic of very big controversial in literature actually. But in this study, we found that mouth breathing had very narrow airway. It's reminded me research from Dr. Virgil Harvard. He used the monkey and he tried to obstruct the monkey nose using some silicone tube. And those monkeys start to develop some habit. Of course, first is the mouth breathing because he obstructed their nose. And also those mice start to develop, monkeys, sorry, those monkeys start to develop some habits such as protruding their mandible and some other craniofacial deformities. So that's why actually mouth breathing is associated with craniofacial growth effect or development. Yeah, also Dr. Melvin Moss, which is founder of functional matrix theory, supported that hypothesis because actually soft tissue may affect hard tissue development. And for nasal breather, their soft tissue component functional properly. I will show you some of our finding in other paper, which we found that mouth breathing has some muscular functions such as masseter muscle function dysfunction. So I will talk about those aspects one by one. And so from that view, we performed the research about which treatment option can facilitate or can help mouth breather during their normal activity. How can we treat them? There is one activity called myofunctional treatment. Myofunctional treatment we used in this study, I was first author as well in this study in China among Chinese children. We use what we call myobrace. Some people they call it trainer for kid, and they have several names. It's type of myofunctional appliance. You can see in this picture, this kid was practicing lip training. There is also, you need to perform or to teach kids to perform some lip training activity to train their lips and also, of course, their muscle, facial muscle. And also you can see in this picture, this kid is trying to train tongue training. So, and other activities. So during this functional training using my functional treatment, we found that people or kids with this kind of treatment had very favorable growth of maxillary arch, and also there is very obvious improvement in their function. So those without treatment, of course, may suffer from open bite, deep bite, and those orthodontic issues associated with mouth breathing. So it's very good approach for orthodontists also not treat teeth by just putting wire and brackets. You can start treating kids at a very young age. Functional appliance, my functional appliance, they work very well. They can facilitate kids. For example, those class 2 case. Yeah, you can use twin block, activators, Franco, and other appliance to treat those kids at a very young age. Normally, in some countries, they are still saying like kid has to be at age 12 to start orthodontic, which is not true. Because you can start treating kids at a very young age, so to facilitate functional growth of their mandible by class 2 appliance, for example, even class 3 using face mask and other appliance. So that's example of one of treatment for mouth breathing using myofunctional training and the treatment approach. But I was also talking about some other activity like the functional appliance. So Dr. Chao Miwe, that was my colleague at Xi'an Liaotongo University, and I and other colleagues. We performed the study published in the Journal for Oral Rehabilitation about electromyography activities of jaw and facial muscle in subjects with different vertical skeletal partner and breathing mode. The purpose of this study was to see if mouth breather and nasal breather had different aspects of their muscle function. One aspect or one area we assessed was masseter muscle, orbicularis muscle, or facial muscle in general. In this study, we found that there was very big difference between two groups where mouth breathers showed reduced electromyography activity of temporalis and masseter muscle during swallowing. This is very critical because it shows weakness of masticatory function of those people. So I suggest my fellow dentists and orthodontists to carefully care about mouth breathing syndrome in all your patients. Because whenever you treat patient with those issue, if patient has adenoid hypertrophy, whenever you treat them, they will end up with failure, relapse of orthodontic, because you need to cure those causative factor such as adenoid. You can send or refer the patient to ENT department. It's better to collaborate with other team member like ENT surgeon, pediatric dentist to treat those issues like mouth breathing. So based on those study, you can see mouth breather has some muscular dysfunction of temporalis and masseter muscle during swallowing. So so this is kind of overview to show how patient cannot be treated just not aligning their teeth, but we need also to focus on their functional habit and also their underlying cause. We published the paper in Angle Orthodontic, focusing on adenoid and tonsil hypertrophy and upper airway and how it's born. So we found that people with adenoid and tonsillar hypertrophy may have airway constriction. This is supporting my previous study I showed. And also they have elevated hyoid bone position, which may reflect like compensatory postural adaptation to maintain airway patency. So this is very crucial because people with adenoid and adenotonsil hypertrophy, they may have very narrow retropalatal airway volume. And actually, most study previous authors suggest relationship between hyoid bone and airway. So this elevated posture of hyoid bone may be associated with that narrow airway in those subjects. So in general, it's also better to assess craniofacial development of those subjects in relation to airway. This study was published in 2024 in Orthodontic Craniofacial Research. I was first author as well. So I did novel prediction model for pharyngeal airway volume based on cranial base, and mid-sagittal cross-section area of airway. The aim was to predict upper airway based on cranial base, such as saddle angle, articular angle, gonial angle, or cranial base length, Najon cella. This is very common. Bijolic polygon. This is very known for orthodontists, bijolic polygon. So I found that some parameters such as Najon cella and mid-sagittal cross-section area and bijolic sum angle were predictive of upper airway. That's mean that not only we can focus on soft tissue, for example, or just airway cross-section, but also we need to care about cranial base, soft hard tissue components, craniofacial structure, maxillary length, and other. So you can even use cephalometric radiograph to predict some patient airway anatomy. So it's possible to use two-dimensional approach to predict three-dimensional approach. In this study also, I found that class 2 subject had smaller pharyngeal airway volume compared to class 1 and 2. And also, clinical implication from this study is even routine cephalometric radiograph can help you to estimate airway dimension and identify people at risk of upper airway. Yeah, that's true, because it's not necessarily that you need to have a CBCT or MRI to predict some patient abnormal airway. Of course, if you have, it's good, but in some cases, it's difficult to have those advanced 3D. So if you have two-dimensional cephalometric, it's possible for orthodontists and dentists to evaluate some factor which may be associated with airway. So my previous study published in international dental journals assessed soft palate. Soft palate, previous study was focusing on OSA. Soft palate is very crucial parameter to predict OSA, obstructive sleep apnea. Those studies said that people with obstructive sleep apnea has very long soft palate in terms of length. But in my study, I used a normal Japanese subject without OSA, without obstructive sleep apnea. So I found that those with vertical skeletal patina, like high angle patient, have long soft palate. Their soft palate length was bigger than other groups. And also those hyperdivergent patients or high angle patients had a very narrow airway. So there was a very specific or very critical association between airway and soft palate. So soft palate was negatively associated with upper airway. Someone with longer soft palate has narrow airway, especially in hyperdivergent patients. Those data also suggest that we need to care about craniofacial structure, soft tissue component, soft palate, and other structure to assess, to know those patients may be at risk of airway collapse or other functional abnormalities during sleep, so that we can treat our patient in both functional and aesthetic. We'll be like proud to see patients smiling, but without any other abnormality resulting from orthodontic. Because we cannot be proud if patient was treated, their teeth are nice, but they have functional problems such as respiratory issue or some other function. So I did a single authored research or review on obstructive sleep apnea recently in OSA, published in Oral. So my research was just to see the role of orthodontists and the non-orthodontic approach, of course, for treating OSA in children and adults. In this study, I found that there is association between, of course, OSA and airway narrowing, retrogression of mandible, and vertical skeletal issues. All those areas can be treated in orthodontic clinic. Orthodontists can treat vertical skeletal issue, can treat mandibular retrusion, can also treat narrowing of maxillary arch by expansion and other approach. So that's why orthodontists can play a very big role in managing obstructive sleep apnea. In that case, there are several approaches, such as maxillary expansion. People reported this to be useful in treating people with pediatric patients. Mandibular advancement using like appliance like twin block and activator or forceps fatigue and mala and other approach also has been reported to be essential for treating obstructive sleep apnea, mainly in kids. So my reviews support evidence that orthodontists can be can play a very crucial role in treating obstructive sleep apnea via different treatment modality. But those can be done with collaboration with other specialties such as ENT, oral surgeons, medicine. Actually, best treatment for all orthodontic case is about collaboration. Collaborating with other departments is very crucial for orthodontists. Okay, besides functional habit and the mouth breathing, we have recently published paper in Journal of World Federation of Orthodontic. In this study, I collaborated with orthodontists from Rwanda and America, United States, Dr. Dimitrios from University of Rochester, is professor over there and friend of mine. So we performed research on skeletal and dental open bite treatment using clear aligner and orthodontic miniscule called fixed appliance. So here we want to see current evidence about treatment of open bite using different approaches. So both clinical aligner and miniscule anchored fixed appliance are okay for treating open bites, but via different approach. Clear aligner primer achieve this by intrusion of posterior teeth and extrusion of anterior teeth and improving anterior occlusal contact and reducing posterior vertical dimension. So, but mufflers, we call it mufflers or miniscule and core fixed appliance, produce greater more intrusion and control anterior extrusion, correcting both dental and skeletal components of opening bite. So it means both can work, but by a different approach. So orthodontic treatment can focus on what you want to treat open bite, which way. How about patient? What patients? Some patients may prefer clear aligner because it's new technology in orthodontic, and they may like aesthetic components. So, but also you need to suggest them depending on which case you are treating and how difficult it is. So care should be taken on those factors to decide which treatment option. Actually, that was aim of this systematic review, to see which one is maybe effective in different case of different patient case. Also, very recent paper we published, also I was corresponding author of this research from European Journal of Orthodontic, also one of the best journal of orthodontic. And also Dr. Dieudonné and Dr. Eric and other colleagues such as Salima from Sudan and Dr. Dimitrios from the University of Rochester and other colleagues like Dr. Eugene Pascal and so on. We performed this study with a big collaboration. You can see several authors contribute to this research. So we want to see how condylar position and morphology can be affected by functional appliance, actually. Evidence suggesting treatment with functional appliance on TMG. Of course, we all know that functional appliance may affect temporomandibular joint through remodeling process at TMG level. So we want to see evidence. We found that functional appliance induce both functional and structural adaptation in temporomandibular joint. And also this suggests biological basis for mandibular growth stimulation. But still evidence remains low to moderate, not very high. So which suggests that this area needs further randomized RCT studies to further confirm this evidence. Also, I found that in summary, I can say functional appliance can induce real skeletal and chondral adaptation in temporomandibular joint region. So, and orthodontists need to understand biology behind those changes. Because moving mandible means you are influencing joint, airway, and all craniofacial system. So you need to care about those aspects. That's why I conducted this study to see available evidence for functional appliance and TMG. So that was part of clinical related research. Actually, there are several research, more than 20. I cannot discuss all of them here. Just I picked few of them. So now I'm going to talk about basic research. So can orthodontists or dentists perform basic research and clinical research at the same time? For me, I performed both clinical and basic research, especially during my PhD course in Japan. My main basic research in Japan was study using mice model of CCN3 knockout mice. CCN3 is one member of cellular communication network family. It contains actually 6 members, CCN1, 2, up to 6. So those genes play very different, very critical function, especially in musculoskeletal biology, development of joints, especially CCN3 has been suggested to be very crucial in cellular senescence and also joint disorders. So my research was to see how CCN3 may affect mice joint, but after performing OA osteoarthritis model. So we used here, this is me, I was performing knee surgery of, it's called DMM model, destabilization of medial meniscus. So we cut medial meniscus to make joint unstable, actually, to make it unstable. So few weeks, especially in my case, I used 8 weeks. After 8 weeks, mice will develop OA, osteoarthritis. So this can also, there are several models. We can also perform model in temporomandibular joint, but here I used OA in knee. I want to see how CCN3 affects those aspects. Also, I performed several other experiments like cell culture and several molecular biology and related experiments. So my paper was published in International Journal of Molecular Science, one of journal which published this kind of research. Its title was Critical Requirement of Senescence-Associated CCN3 Expression in CD44 Positive Stem Cell for Osteoarthritis Progression. So I cannot discuss all of this content, but I would just say like take home message from this study. As I said, CCN family contains 6 members which involve cellular protein in different biological processes, such as proliferation, differentiation, and extracellular matrix regulation. So for my case, I focused on CCN3, which is also known as NOV, has been implicated in skeletal development and cartilage hemostasis. I already discussed about this. In this study, I used CCN3 knockout mice and CCN3 wild type mice. So we initially we did knockout to knock out gene of CCN3. As you can see here, I'm not sure if this picture is very clear here. You can see wild type DMM. This is wild type mice with surgery, OA model. This is sham without surgery. If you can see clearly in this knee joint side, you can see very severe damage of this joint compared to this. This joint is kind of intact. But you can see in wild type mice, there is very severe damage, actually, no proteoglycan level at cartilage site here, you can see. But in knockout mice, there is no difference between DMM and sham group. Even we performed ORI score, which shows severity. Wild type DMM has very severe degradation of vertical cartilage compared to other groups. So those data suggest that CCN3 knockout protect mice from OA-like pathologies. So knocking out CCN3 can be very useful to protect mice from OA osteoarthritis, from this research. So we performed several other in same experiment. Here you can see this is immunofluorescent. So we checked if CCN3 has very close relationship with CD44. You remember in the title there is relationship between CCN3 and CD44 positive stem cell. In wild type DMM mice, of course, there are very few CD44 as well as CCN3 is there, but even those CD44 are like colocalized with CCN3. There is colocalization between CD44 and CCN3. So this colocalization actually shows very close association between CCN3 and CD44. So from this study, we keep checking why there is this colocalization. And we checked other aspects, including proliferation, using proliferation marker KI67. I'm sorry, figure is not here. I just picked a few figures. I thought I had it here. So then we checked colocalization between Ki67, which is proliferation marker, and CD44. Then we found that in CCN3 knockout mice, there is increased proliferation of, especially during OA. KO mice showed increased proliferation of CD44 positive cell. That's why actually there is less OA pathology in KODMM mice compared to wild type group because of proliferation of CD44 positive cell during OA. So we performed in vitro experiment, as I said, cell culture, and to see effect of CCN3. In this, for example, you can see increase of CCN3 after interleukin-1 beta stimulation. This interleukin-1 beta is mainly used to stimulate OA-like pathology in cells. So to stimulate cell to mimic OA-like pathology, we use interleukin-1 beta. Some study use TNF-alpha and several other molecules. But in this study, we used interleukin-1 beta. So in this control group with interleukin, there is increased CCN3. But you can see after CCN3 knockdown, CI CCN3, the SI CCN3, there is a downregulation of CCN3, of course, because we downregulated CCN3. But if you see MMP13, after interleukin stimulation, also there is increase upregulation of MMP13 after interleukin-1 beta. Those event was reduced after knockdown of CCN3. You can yes, of CCN3. So which means CCN3 knockdown may reduce inflammatory response of interleukin-1 beta. Same for ADAM-TS5. ADAM-TS5 also, you can see in interleukin-1 beta, there is increase of ADAM-TS5, which was reduced after CCN3 knockdown. And also you can see COR10A1. This is a mark of hypertrophic chondrocyte, was also increased in interleukin-1 beta stimulation, which was reduced after CCN3 knockdown. And there is interesting finding here, P21 or CDKN1. This is a mark of cellular senescence or cell cycle arrest. So also shows similar trend to those factors, which means CCN3 knockdown may prevent or may reduce events of OA like caused by interleukin-1 beta, also may prevent cellular senescence or cell cycle events. So it may reduce cell senescence during OA stimulation. So knocking down CCN3, you can see play very crucial role in protecting, as I mentioned before, protecting mice from developing OA-like pathologies, even in cellular or in vitro experiments show that knocking down CCN3 may reduce interleukin-1 beta OA-like effects. So those about of CCN3 molecule in OA-like pathology. So I was talking about this, and also we for orthodontists, also we need to know mechanism behind orthodontic tooth movement. Because during when you move, you try to retract teeth, there is some event. It's not like there is there isn't how can I say that there is no magic between retracting teeth and movement. Those are kind of events which happen on tension side and the pressure side. So we need to understand which mechanism happened during orthodontic tooth movement. Osteoblast function, remodeling process, which molecules. So from this view, we performed a comprehensive review of a biological mechanism in orthodontic tooth movement. The aim was to see how basic research can happen or can prove what is happening during orthodontic tooth movement or other clinical research or other clinical outcomes. So we found that osteoclast, osteoblast, and precursor cells and osteoclast, osteocyte, they may behave in response to mechanical stress. So their remodeling process during tooth movement, it's very known. And when you retract teeth, there are some cascade of events which may happen. So those movement may cause osteoclast to function by resorbing bone and osteoblast to form bone. Those kind of movement called remodeling process happen during tooth movement. So it's better for orthodontists to understand how those molecules happen, function during orthodontic tooth movement. Several clinical research and basic research now are exploring several molecules such as prostaglandin, such as piezo 1 and piezo 2. Those are transduction molecules, and TRPV4 and several other molecules are now. If you see in AGODO or ANGO, recently I received several research working on those molecules to review them. So there are several interesting article even published now talking about tooth movement. What's happened during tooth movement? Which molecule can stimulate tooth movement? And also there are some other way to accelerate tooth movement. So by perforation, by incision or something. So all those are to see how our future as clinician orthodontist can contribute to this kind of treatment approach to make better for patient and to make sure everything is working properly. So I can conclude that dentists and orthodontists may play vital role beyond clinical practice, contributing to basic and translational research in craniofacial biology, bone remodeling, and tissue regeneration. So by bridging clinical and the lab, they advance patient care, develop novel therapies, and also expand our understanding on fundamental biological process. So here you can see I was performing animal model using mice. Here I was doing cell culture. At the same time, I was treating patients. We cannot focus on one thing to achieve better. So we can just combine both clinical and basic research to make sure our patient will actually benefit from what we are doing. So my research, the one I showed before, got prize from Japanese CCN Family Society as best research and I was awarded Global Research Promotion Award for Young Scientists from CCN Family of Japan, whole society, like whole country and CCN Family. And if you need to see or like it's difficult to present or research in one slide, it's a lot and it may take time. You can check my research gate. My name is Janvier Habumugisha. You can check my Google Scholar and also you can check all ID so you can find those information. So thank you so much for your attention. If you have any question and suggestion, anything, you can just talk to me and you contact me via this email if you need to collaborate with me for future research. So you're welcome for any kind of collaboration. Thank you so much.
Thank you. Thank you, Dr. Habumugisha, for a wonderful talk. And I believe every one of us, we've learned one or two things from the talk. So if we have questions for our guest speaker this afternoon, you can either just put up your hand or unmute yourself and ask them questions. I believe there are one or two questions that we might want to ask him this afternoon. Or maybe you have a request, though he already said earlier that if you want to collaborate with him, it's open to collaboration, but I believe one or two persons have one thing to say. So Dr. Abu Shaguya, you can unmute yourself and ask a question.
Thank you very much. This is an exciting venture. Thank you so much for organizing it. And Dr. Habumugisha, we are proud of you. I am East African. I am Ugandan. I am an orthodontist in Uganda. I
Thank you so
am
much.
excited. I am interested in sleep apnea as well. It's
Okay.
exciting that you're putting out so much work, but I feel bad that we haven't done anything about sleep apnea in our population.
Okay. Yeah.
From all your studies, I haven't seen anything from East Africa, and
Yeah,
I haven't
you're
seen
right.
anything from either Kenya or Tanzania, or I haven't
Yeah.
seen any actual sleep apnea
In
papers being
Africa.
written
Okay.
about the African population, which
Yes.
brings the question is, I keep wondering if we really have sleep apnea here in Africa. I'm curious
Okay.
to see what the results are. So it's something I would like to follow you up on, and it's something I would be interested in working on with you, as well as well, I'll follow up with your email because you shared your details. And
Mhm.
then the other question I had is, are you in academia at the moment? Are you teaching at any university? Yeah. Thank you very much. And great presentation. Thank you. And I am proud
Okay.
to see how hard you're working at such
Mm.
a tender age. Thank you.
Thank you. Thank you, Dr. Segaya. Sorry, your name is
My name is
Ken?
Abdul. I think it's easier for you to say
Abdul.
Abdul
Abdul.
because
Okay.
there's an Abdul in every
Okay.
country, so I'm sure.
Okay.
So
Thank you, Abdul. Okay. Thank you, Dr. Abdul, for a very great question. Actually, yeah, all my research, I did all those research in different countries, in China and Japan during my master's specialty and my PhD course. Yeah, but it's now, I can say I'm going to start to work on those issues in Africa, in Rwanda. As you can see now, I'm here in Rwanda. So my next like, mm, my future direction on this, or say obstructive sleep apnea, will be in those East African countries or Rwanda, Uganda, and Kenya. We can collaborate on those kind of research because everywhere we can have those patients. Because we can have people with OSA in any orthodontic field or clinic. So I can say, yeah. So we are starting now to work on those in Africa. Actually, there are very few research in Africa, clinical research, especially. Yeah, because maybe you can say a tool for examination and three-dimensional study are very difficult to perform because of equipment. MRI, CBCT, not all clinics has those tools, but we can try. So my next target is to do those kind of research in OSA in Africa, in Rwanda, East Africa. So Abdul, please let's collaborate on this. I'm happy you are interested in this area. And hopefully in future I can have several other findings on this issue or say it's a very, very dangerous issue actually, which may affect kids, adults, any kind of age. People may suffer from that. And also, as I said, orthodontic treatment may have such kind of influence on that. If you treat patients, for example, with mandibular setback, and the airway may have issue, and it's a very big, very dangerous thing to do. So we need to work on this in our population in Africa. So next destination is Africa, Rwanda, Kenya, Uganda. So let's go for it. And thank you for your interest on my research. So your second question, actually, I just finished my research at Okayama University a few months ago. I moved back to Rwanda. So I'm still new to Africa after 7 years, actually. Yeah, I stayed in China for 4 years and 3 years in Japan. So now I'm starting new life in Rwanda. We never, actually, I don't know, but hopefully I will be an academic, yeah, helping, like sharing my knowledge to Rwandan student or other people who like to work on this career of research and clinical. So probably I will be in academic and clinical research both. I wish. So let's keep in touch. We can collaborate in any kind of research, and yeah, you can contact me on that email. So keep in touch. Thank you so much.
Thank you, Dr. Habumugisha, for answering the question. I know we have a few minutes left. Any other question for Dr. Habumugisha? So as people are thinking of their question, I have this question for you. So I saw the transition from clinical to the basic research, which you did during your PhD program. And
Yes.
I personally, I actually did that. So, but I want to, because we actually have some people here that they are just dentists and just doing clinical work or clinical research, and they've been thinking of how can I move from just being a clinician into basic research. Can you just tell us a little bit about, do you have to do some bridge program to bring you up to speed or to upskill you in terms of going into the laboratory research? If you can just give us more details on that.
Okay. Actually, thank you for your question, Doctor. That's very great. Actually, it's not easy journey to do both at the same time. You need to sacrifice your time, and you need to finish first your clinical research, and you need to make your schedule. You need to make sure which one will come first, which one will come second. Because during my PhD, I was supposed to do both clinical and basic research. So there was two different departments, orthodontic department and basic or molecular biology department. For instance, I was working on Monday to Wednesday in the clinical room. Then Thursday, Friday, I have to go for basic research. So it's something they will train you. In Japan, they have I think, very good teaching way in terms of equipment. If you need to learn about PCR, it's easy. You can learn it in one day. They will show you how PCR machine is working and everything from zero actually. Because as you say, we are dentists, we don't have such kind of skills in basic. But they will show you, and they have facilities for mice, for monkey, for dog, fish, pig. So you can use any kind of animal in this. So what run how to do those kind of basic research? Yeah, it's possible like to find those institutions for, especially I can recommend you Japanese university. They will research teaching way, so you can learn both at the same time. But I can say you need to sacrifice your time. Sleeping time, you need to reduce your sleeping time. Personally, sometimes you can sleep to a few hours per day just doing clinical, and after you go for basic research, You finish at Ture, tomorrow you go back to clinic. After you finish, you go back to basic research. So it's all about arrangement and your passion, what you want. It's possible. And those techniques are not difficult to run. Basic research, cell culture, and animal. Maybe animal is kind of tricky because you need someone to train you how to cut mice knee joint, how to see meniscus, anatomy, those kind of stuff. Yeah, it's possible, but it needs sacrifice. Yeah, it needs sacrifice. But it's possible. If you want to go for those are kind of postgraduate course like PhD, yeah, I can recommend you Japanese university or Chinese university can train you for those translation from basic and clinical research. And also there are possibility you can do like one, just focus on basic research. Both is also possible. There are some institutions that can help you to train yourself in basic research. But for me, I was doing both at the same time. Did I answer your question well?
Yes, thank you, Doctor. So, because we actually out of time, but I think Dr. Agnes or Prof. Agnes has been up here. So, can you take your question? You can unmute yourself.
Yes, thank you, Dr. Temilola. If I if I spell well your name.
Yeah,
So
Dr. Temilola.
Yeah, thank you. Me, it's a word of appreciation. I'm Dr. Agnes Gataraiha. I work at the University of Rwanda. So I want to congratulate Dr. Janvier. He's a very bright, since he was a student, he was my student.
Thank you.
And then I would also recommend, as with this platform is for the whole, for Africa, that we can do more collaboration and we do more research, like because what he has done is innovative ideas. And then there are a lot of things that can be done, even if when you go in the systematic review, searching for the studies that can maybe articles that has been done in Africa, you find that they are very less, or little, even if there is even zero. So I think this is the time for Africa that we can do a lot of together. So congratulations for a good presentation, Janvier.
Thank you, Doctor.
Thank you.
Thank you.
Thank you.
Thank you, Prof. And I think I also need to mention this also, that also here at the University of the Western Cape, we actually doing some form of developing dentist scientists in terms of clinic. We doing training dentists that doing clinicals and also doing basic laboratory work. And I think we actually just have a new student in Rwanda presently. Is going to be doing something on oral squamous cell carcinoma, actually doing molecular study on that. So we also have students in Kenya, in Uganda. They're actually here listening to you, and also Nigeria, Ghana, and co. So I believe it's a right time for us to develop dentist scientists in Africa, not just focusing on the clinical aspect of dentistry, but actually doing the basic and laboratory studies in Africa. And we can also, yes, also collaborate. We actually have a co-supervisor there in the university in Rwanda that will be working together with regards to so we're still open for to getting more students and also include more countries also on the project also. So it's open for collaboration for as many that want to collaborate on that. You can always contact us also at the university. You can write an email to us and we will respond to you. And I think there's no other question more. We want to appreciate you for your time for coming to speak to us and giving us this wonderful talk. And it actually showed the hard work and the effort you have put in it all along. Thank you very much. And to everyone for coming here to this platform this afternoon, we want to appreciate you. Thank you. And see you next month.
Yeah, thank you so much. First, before finishing, I want to thank Dr. Agnes my former teacher who invited me for this event. Thank you so much, Dr. Agnes. Yeah, I'm happy to share my talk today to everyone here, and also thank you for coming for today's talk. So, yeah, as you say, we can keep in touch and collaborate, and yeah, future is ours. Thank you so much.
Thank you, everyone. I think someone just requested for my email, so I will just drop my email also on the group so that everyone can see in case you want to write for collaboration. Thank you, everyone, for coming. See you next time.
See you. Thank you so much.
Yeah, bye. So I have my email on the group. You can copy and send an email to me if you need more information on collaboration. Thank you. Thank you, Dr. Habumugisha.
Thank you,
Hope to see
Doctor.
more of
Thank
you.
you for for your time.